Hello, and thank you for joining this OncLive TV peer exchange. Modern treatment of advanced lung cancer is based on tumor histology and molecular subtype, with new advances in the field happening at an accelerated pace. This panel discussion will focus on the latest information on advanced lung cancer coming out of ASCO 2015 and will provide important context around the data. My name is Dr. Mark Socinski, and I am Director of the Lung Cancer Section, Division of Hematology Oncology, and co-director of the UPMC Lung Cancer Center of Excellence at the University of Pittsburgh. Participating today on our distinguished panel are Dr. Mary Jo Fidler, an associate professor and lead of the Lung Cancer Translational Research Group at Rush University Medical Center, Dr. Roy Herbst, Ensign Professor of Medicine, Chief of Medical Oncology and Smilow Cancer Hospital, Yale Comprehensive Cancer Center, Yale School of Medicine, Dr. Jeff Oxnard, an Assistant Professor of Medicine at Harvard Medical School, and Dr. Nair Rizvi, Director of Thoracic Oncology and Director of Immunotherapeutics at Columbia University Medical Center in New York. Thank you all again for joining us. Let's get started. We want to start with the latest news in targeted therapy, and that's the approval of gefitinib for the use in EGFR mutation positive patients. And so, Dr. Fidler, could you kind of summarize that data and put your thoughts around it?
Sure. So the IPASS trial was the first trial that showed the importance of molecularly selecting patients for first-line EGFR tyrosine kinase inhibitor therapy. And that trial showed the progression-free survival benefit that most of us have seen with gefitinib compared with carboplatin and paclitaxel. And that benefit was repeated in a randomized trial in Japan with gefitinib and carboplatin and paclitaxel. And now we have data from a phase 4 trial in Caucasian patients using gefitinib in patients with EGFR activating gene mutations. And that trial did have some interesting features. First, the outcomes were what you'd expect with gefitinib in this setting with activating gene mutations with a favorable response rate, favorable progression-free survival. But as part of the study, they analyzed patients' serum compared with tissue to see if you could detect the EGFR gene mutation with a blood test compared with tissue. And though tissue certainly is more sensitive, the trial showed that you can in fact detect the EGFR gene activating mutation in serum, which I thought was pretty exciting.
Yeah, so Roy, this is, you've had a lot of experience with gefitinib over the years. We have obviously erlotinib and afatinib in this space. How does gefitinib add to that? What are your thoughts? How do you fit it in?
Yeah, well, this is very interesting. You know, we've always known this is an active drug. The first trials, I think we first used this in 1998. Yeah. And actually, you know, historically, gefitinib was the first EGFR inhibitor approved, and of course, the randomized trial just missed its endpoint because we didn't know about EGFR mutations back then, and that smokers do worse than non-smokers. But you know, the drug's been used for many years in Asia and other places. So the fact that these trials now have resulted in its approval, I think, are a good thing. It gives us another alternative to use. You might say, how is it different than erlotinib? It's not much different. Although at the dose that it's prescribed, you know, I think the toxicity is perhaps a little bit better. You know, many times with erlotinib, you start at 150 milligrams and you have to dose reduce. I think erlotinib is a great drug, but I think gefitinib at 250 milligrams might be a very good alternative.
I mean, gefitinib is a nice example of a drug being developed at a biologically effective dose way before we knew about mutations.
Exactly. So it's great to see, and you know, it just gives us, now we have multiple choices for these patients. Of course, we're moving on to the next generation of drugs. But I know that, you know, at my center, we're beginning to use it. We talked about it at the conference this morning.
Yeah, it provides another option for patients with EGFR mutations.
Absolutely.
Mark, some docs like gefitinib because it's flat dosing. You don't have to dose adjust. You pick a dose and stick with it. Versus erlotinib has some flexibility because you can pick a dose and then you scale, but it's a little more work to find the right dose for the patient. So
Roy mentioned, you know, the gefitinib, erlotinib as first-generation drugs, afatinib as second-generation drugs. We're now on the brink of another third-generation drugs coming in. You know, I always